Pain management for all ages, 0 to 190 minutes. Our speakers are Maureen Lynch and Maria Rugg. Maureen Lynch has extensive experience in oncology, pain and symptom management, and palliative care. She is currently the nurse practitioner in the Adult Palliative Care Program at Dana-Farber Cancer Institute and is on the faculty of Harvard Medical School. She has published and presented nationally and internationally. Maria Rugg has extensive experience in pediatrics, palliative care, bereavement care, pain and symptom management. She works as an acute care pediatric nurse practitioner at the Hospital for Sick Kids in Ontario, Canada. Thank you, Maria and Maureen.
Thanks, Nancy. We're going to tag team here, so if we get confused, we'll reorganize very quickly, but we're going to try and make this as interactive as we can. So thank you all for having us here this afternoon. Our purpose really is to try to show you how much adult and pediatric pain management blend together, and that there's really just certain places where we kind of veer off into slightly different, not even directions, but that we apply the knowledge that we have somewhat differently in adult and pediatric. So we're going to move through this quickly. So definition of pain is universal. It's from the International Association for the Study of Pain. It says that pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in such terms. So it's physical, it's emotional, it means that something is wrong. That's what that definition means. Margot McCaffrey, back in 1969, said that pain is whatever the person says that it is, and it exists whenever he or she says that it does. Pain is subjective. The only person that can really tell you if they're in pain is the patient. So that leaves us, of course, with the question of what happens when the patient can't communicate, which is a huge problem in pediatrics, because sometimes the kids just don't have the verbal skills or the cognitive skills to tell us that. Cecily Saunders, the mother of modern hospice, reminded us that pain is total pain, that you can't have just one kind of pain, that if you have physical pain, it's going to affect you emotionally, socially, and spiritually. If you have a social loss, that it can also affect you in all of those domains. So it's total loss, total pain. So we're going to talk about, as we talk this afternoon, we're going to follow two cases. Henry is a 32-year-old man with a recurrent osteosarcoma of the right leg. He has pain in his right hip area and mid-low back that is not relieved by taking 2 Percocet 5-325 tablets every 4 hours.
And Sally is a 15-year-old girl with a metastatic osteosarcoma. Her pain has been managed with hydromorphone, 10 milligrams of long-acting BID, and 3 milligrams short-acting Q2H PRN for breakthrough. So what further assessment do we need to develop a pain management plan for these two individuals? So the pain experience, what is it? So this mnemonic is a way to kind of help guide you in the beginnings of what do I need to ask, what do I need to think about. So place, obviously, where is it? Amount, how much? Intensifiers is, what makes it worse, what makes it better. Again, the idea in this mnemonic is that we're trying to take that total pain experience and get it down to some key questions. Nullifiers, what makes it better? Because what makes it worse and what makes it better may be two very different things. Effects. Does the medication help? Does it not help? Does it make other problems appear? Are you taking any medication? How is the pain affecting the quality of life? So that idea of the experience. And then further to that, what does it feel like? Because that's going to help guide you in terms of what's the plan going to be. So we use language around feeling that best meets what the patient can describe. So when we talk about how we're going to get through this pained experience, what do we generally do? We have some tools that will hopefully help us, not just for the patient or person who can't communicate, but also in terms of helping us identify the things that we should be asking about. So we have the intensity scales that will tell us to a certain degree in valid, reliable form across the board what that pain rating is. So they're numeric scales, 0 to 10, simple. Sometimes they're verbal descriptor scales, no pain to as bad as the pain could be. Visual analog scales, so some of the FACES scales, which we'll show you some pictures. The Bieri FACES pain scale, and the pain thermometer. Does anyone have any experience using any of these? Yes? Yes? So they're not new. Okay. How is that different than a pain assessment tool? The limitation of the intensity scale is it's just going to tell you what it's like, right? How much. The pain assessment tool tries to bring in the rest of that pained mnemonic, that experience. So two examples and ones that have been well documented in the literature in terms of the reliability and validity would be the McGill short form, yay Canada, and the brief pain inventory. And what I mean by yay Canada, the McGill short form was developed at McGill University. Anybody have any experience using those scales? No. So we'll talk a little bit more about those. Here's an example of what the pain intensity tools may look like. Here's the FACES scale. And in fact, we're going to talk a little bit more about the pediatric piece of this, but we've gotten away from the FACES scale, and I'll give you the reason why in terms of pediatrics. We prefer the Bieri scale, which is on the bottom, as you see down there, and the reason being is because with the FACES scale, as you can see, 10, the face is crying. And what they have found is that more reliability seems to come from a scale that shows discomfort versus the tears, because the tears brings in an emotional component that may be identifying with sadness versus the pain. And so they find that it actually more accurately reflects the actual pain intensity versus the emotional component that goes with. Assessing pain in the nonverbal adult. So while the tools are helpful, what are we going to do for the person who can't speak for us? And I know that you have some great symptom management gurus in the United States out of the University of San Francisco, and they talk about the importance of, while the golden rule is the pain or the symptom is whatever the patient says it is, the next golden rule to that, and they say that for pediatrics, but it can be even for the nonverbal adult, is the caregiver or the parent. That's the next best person to get the information from. So certainly the facial expressions, behavioral changes, any sort of verbalizations, most tools will look at these 6 types of things and have them rated, and you as the rater or the caregiver as the rater describing them, so that you can all together put those pieces all together to get hopefully an overall picture of what that patient is feeling without them having to tell you. So here's some examples of some tools that are used for different populations. Activity and function changes, again, that relates to hoping you need to obviously get some degree of a baseline. And again, that's why it's so important to get a primary caregiver. Some sort of a baseline. What was it like at the baseline? And then what are we going to do? Assess it again later, so that you have an understanding if there's a change. So again, it's really important to stick with a tool, not to change tools. So as the caregiver or the caregiver that you're getting the report from, in terms of your observations, if you start changing tools, that becomes confusing, because then you don't have any validity to say, well, this has been consistent over this course of time. Protective actions and then proxy reports is what I talked about, the golden rule. If you can't get the person to tell you, the next best thing is that primary caregiver, and in terms of pediatrics, whether it's the parent or whoever, is the next best thing. The nurse, and certainly again the symptom management groups would say the nurse who is consistently going in would be the next best proxy report. And I was just going to say, Maureen, jump in anytime if there's anything that I'm missing. So how do we continue on beyond our tools? Obviously, what we talked and what you saw this morning, a good pain history. What does that look like? Well, let's make sure that we understand, what did we use before? Have we been using anything before? Has there been any analgesic use? What, over the duration of time, what's the pain been like? Medical history. What's their diagnosis? Again, how important is that? We heard already yesterday. We'll have an idea better of what we're seeing if we have a good idea of what the diagnosis is about. What's the prognosis? Why is that important? Because that'll help guide you in terms of what direction do we need to go here? What's the priority in terms of this management? And what are the comorbidities, other health problems? Those things are obviously going to affect. Psychosocial history. We need to look at their history of substance abuse. Is there any history? Is there a family history? And again, that will help us to understand what medications are going to be of best use for this individual. Are there any psychiatric diagnoses? Why do you think that would be important? Again, a medication history as well, that's one thing, and also their ability to report and how is that affecting their reporting. The physical exam, obviously, the eyes, the ears, the hands, the touch, everything that the nurse does, very important. And then diagnostic tests, again, going back to what Patrick and Jody talked about this morning, let's decide what's most appropriate and what's going to help get us to the best plan as possible. We're not going to do a CBC or a CT just for the sake of it. What we'll do is that going to help guide us into getting a more detailed assessment of what's needed here? Is it going to add to the information if we're not able to get a lot of information from the patient? Clear information. Further to your initial assessment, obviously, is ongoing assessment. So again, that idea of once we start putting interventions into place, we don't stop assessing. We're continually using them on a regular basis, and that's what helps in terms of the validity and the reliability of those tools, is that we're consistent in the type that we choose and that we're doing it on an ongoing basis. An example I will give you just in terms of our practice, I know that we have a pain service at the hospital, and part of their initial assessment when they go in, they figure out which tool is going to work best for that child and family, and then every day when they round, they go through that again. Every day, they try to get a baseline. Where are we today? So in terms of what are we looking for, was the intervention, whatever it may be, was it effective in terms of, has the pain intensity changed? Has it changed in terms of quality or location? Has it changed in terms of the amount of medication that we're using and type? And again, that'll help us. Do we need to go up? Do we need to cut back? Are there changes in function? Has their quality of life improved? Have we been able to make any gains? Or has it gotten worse? Are we able to do the things that we were wanting to do, or has it interfered? And then we need to make sure we understand the side effects of medication. And we'll talk a little bit more about these as we go through the presentation to understand what do we do about them. But these are the more common things that you will see: sedation, respiratory depression, nausea, constipation, itching. Measuring pain in children. What we don't have, which is great for the adult population, less great for pediatrics, is a lot of reliable and valid tools. What we do have the luxury of, though, is that there's more and more research coming, and we try to gear those to age groups. which obviously makes sense. What do we need to think about when we're thinking about children is making sure that it's something that the child can use, or it makes sense to the child and family in terms of their understanding of their pain, which is based on their developmental age. Now, we're not necessarily talking about chronological age, and I think that's an important thing to remember when you're doing measurement and assessment of pediatric pain. It's not necessarily always about chronological age, it's about developmental age. So in terms of some of your children with pediatric oncology diagnoses, sometimes they've been through certain treatments and they have had some neurologic deficits as a result of those. Or just, your average 7-year-old may not be your average 7-year-old. They may be much more mature. They may be much less mature. And part of that comes from your ability to kind of have an assessment and have a toolbox, as one would say. So the methods that we have available are self-report, obviously, behavioral indicators, and physiological indicators, just like the adults. General guidelines: if one doesn't work, throw it out, try something else. And the kids will tell you right away, that doesn't work. And I'll give you a clear example. We had a young child who she was fairly young, and she's about 3 years old, and you'll see there aren't a lot of tools out there for 3-year-olds. But she had an underlying condition from the time of birth, so she's lived with this disease for her whole life. We tried to use the FACES scale. 1 to actually, not even 1 to 10. It was just the FACES scale, no numbers, because she was fairly mature for age. She was verbal, able to describe. Didn't work for her. She wouldn't look at you, she wouldn't talk to you, she wouldn't do it for her mom, wasn't working. In our conversations, and very quickly, I found out she loved Dora. I have a lanyard that I wear at work, a couple different kinds to appeal to the different age groups, that had Dora. And anytime I came to speak to her, she'd have a look at my Dora and talk about how much she loved Dora. So we came up with this idea. What if we made Dora into the FACES scale? So what we did was a little bit of copyright extensions, and we changed Dora up a little bit. And we made Dora like the FACES scale, but we put it down from 10 to 3. No pain and a lot of pain, with Dora being happy and then very sad. And it was phenomenal, because for this child, Mom knew she was in pain, but we needed her to tell us if the medication was working or not, and the scales just weren't helping us gather that well, so it worked. So we try, we throw out something, we adapt. My nurse research colleagues would say, that's not valid, that's not reliable, but it worked. So you have to try to adapt to what will work, keeping the same ideas in mind, because you do want something that's going to give you some incremental, this is doing what it's supposed to do, which is show you if it's getting better or not. Reassess often, document your results, and remember that measuring pain intensity is just one of the aspects. So we have to gear it to developmental age of the child. Here's an example of a pain measurement tool for children with neurodegenerative impairment. And again, it's the same idea as with adult. It's very difficult to see, but the reference is on the bottom of your chart, and it's called the NCCPC-R. Non-Communicating Children's Pain Checklist Revised, and really because there's 3 different tools. There's one for children with acute pain, there's one for children post-operatively, and this one is for regular ongoing pain. And if you go through it, you'll see at the top it talks about vocalization, social, facial, anxiety, physiological, eating, sleeping. So all the same things that you're looking for the non-communicative adult. So when we talk about development, generally in pediatrics, we talk about 0 to 18. And the big thing to think about in terms of measuring and assessing pain in an infant is remembering that as young as 24 weeks gestation, feel pain. It's been researched, it's been shown, it's been demonstrated. Dr. Anand, I'm not even sure where he is these days, but he's shown that it's there. So the idea that not to worry about it, they're not going to feel this, or they don't have the brain development, not true. The issues for birth to 2 years is just making sure you give the family tools to recognize that that babe is uncomfortable. And nobody will know better than those parents what that cry means, what that facial look means, what that extension means. But what you have to do is you have to ask them. You have to give them those tools to know what to look for as well. Here's just some examples that we use, the FLAC scale, the CRY scale, the RIP scale. Again, what you use, for me, it doesn't matter. So long, these ones have been tested and reliable and valid, but it's important to recognize at the end of the day that they all look at the same thing. There's self-report, which doesn't exist, but asking the parents would be, the proxy report. Behavioral things, absolutely, and physiological. As we move up the scale, we know that developmentally, the CNS is fully developed by the age of about 2 years old. So what's the developmental task at that age? Autonomy. What do we need to think about? They have much more language development, but maybe they don't have all the right words that we put out. So if you ask them about shooting or burning, that's not going to mean anything. Find out what are the words to describe something for them. Find out from their parents. Talk to them. They don't have a lot of logic and reasoning. This hurts and this hurts me now. Do something about it. So what are the tools that can help? You heard Jody talking today about cars and how many cars. That's great. We had a young boy with stage 4 neuroblastoma last year who I don't know how that young man suffered so much and was still able to play. And he was 5 years old, and he was on about 200 milligrams of fentanyl an hour, and still suffering. And what this lovely resident that we had with us on our palliative care service did for him was try to talk to him about the pieces of his pain. But again, none of these things were working. The poker chip tool, the faces tool. He loved Buzz Lightyear and Woody. So Buzz Lightyear and Woody, happy face, sad face, and I'll tell you, this resident, I've not seen anybody work so hard. He took hours to develop these little poster boards for him, and it was phenomenal. But again, it's got to work for that child. And for him, he was able to talk about Woody's, what is it? No, it was Buzz Lightyear, and how Buzz Lightyear had that, what did he have? He had a little sword, doesn't he, Buzz Lightyear? Something like that. Anyway, they used it in increments to show how many pieces or how much of his pain, and he usually, for him, it was always lit up. And as we moved along and got his pain better under control, it moved down. But that worked for him, and we were able to get a handle on that. It's important to remember for this age group that they can describe their pain using drawings, so that's great. So, a stick man, it's okay. Colors, they understand their colors. So, red means a lot, blue means 0, and that's good. Children as young as 3. And so that's really important to remember. In particular, with a child who's had a long-term standing disease, they will be able to give you the information if you give them the right tools. For the next age group, symbolic expression starts to develop. So symbolism starts to become important. So the child really appreciates involvement in choices. Things are usually behaviors usually about rewards and consequences. So remember those things. And again, for all you nurses out there, you think Piaget, I put him away and I don't want to think about him anymore. You know what? He is so ever prevalent in terms of helping us understand where we need to be with the child's development. Most of the scales in this group, children can rate their own scale, but they still tend to prefer pictures. Don't give them too many choices. 0 to 10, too much sometimes. I don't know, I'm sure you have not the Wong faces, not Wong Baker faces scale, but there's another scale that has, and I can't remember the name off the top of my head, where you have 0 to 100 and then pictures of actual children. And there's one that's available for African-American children, pictures of African-American children, pictures of Hispanic children, Asian. So they've tried to be very culturally appropriate. But for this age group, usually under 7, 0 to 100, too many choices. Prefer the pictures. So a scale of 3 to 5 or 6 to 7 usually works a bit better. As you start to move up, logic and reasoning is far more developed. Imagination and creativity. Again, you can use creativity for very young as 3, but the numeric scale tends to make more sense. A visual analog scale is great. Adolescents have cognitive understanding of adults, and you may see some children as young as 8 being able to have that same ability. This is where that history is so important. It's so important to remember what is this child's history, not just in terms of pain, but their life history. And so the example I will use for you is that in Canada, we have many children, and I'm sure you have it here too, who are from war-torn countries. Their ability to understand suffering and pain and tolerance is so much different than your average 7-year-old who's never had the experience of any sort of illness. So it's just so important to remember what's the history here and to get an accurate picture of what their life was also like. In terms of the adolescent, again, emotional needs. Need to include them in the process, need to respect their privacy, and need to respect their pain reports. And also respect when they say, you know what, I just don't feel like it today. I've had many kids say, put whatever you want, a 10, a 0, I don't care, just get rid of this pain. So for me, the important part to remember in terms of this population is you've got to develop a relationship and get to know them and know what means something to them. So find that in, and once you're in that in, they'll give you the information you need to help them, but they need to trust you first. And I mean, that's just basic development in terms of adolescence anyway. I'm going to let Maureen take over.
Oh, don't go too far.
No.
Don't go too far. All right, so we do all of this for Henry, remembering he's an adult, so we can use the pained mnemonic and ask some histories about his past history. And so what he tells you is that his pain is a constant deep aching, 6 on a 0 to 10 scale. It increases with walking. It awakens him at night. The Percocet gives him about 50% relief that lasts 2 to 3 hours. He doesn't feel like he's having any significant side effects in terms of sedation or cognitive changes, but he notes that his activity is increasingly limited by the pain. His last bowel movement was 3 days ago, and he has a past medical history of a bleeding gastric ulcer that was treated 2 years ago. On exam, he's tender over the L1-2 vertebrae. His right hip range of motion is limited by pain, and he has 4 to 5 muscle strength in the right quads. A recent CAT scan of his pelvis showed metastatic disease in the right ischium, but no fractures. His last spinal MRI was done 6 months ago and was negative for any metastatic or degenerative changes.
All right, so where's Sally at? Her pain is a constant 8 on a scale of 0 to 10. Increases with little notice. It awakens her at night. The hydromorphine gives her relief that lasts 2 to 3 hours. No complaints of sedation, drowsiness, or itchiness. She has limits in activity, last stool about 3 days ago. Past medical history, she broke her arm playing volleyball about a year ago. She's now complaining of new pain in her left arm, which is the site of recurrence. She describes new pain as a shock, like when you walk across the carpet and then someone touches you, or you touch someone. It spreads down her arm and is not relieved by breakthrough doses of hydromorphone. On exam, she's tender over the scapula. Left arm range of motion is limited by pain, 3 to 5 muscle strength in the left biceps. Her recent CT scan of the lungs shows metastatic disease, questionable bony mets from old fractures. And a spinal MRI was last done 6 months ago for negative, and was negative for metastatic or degenerative disease.
So the next question you need to say is, how will we improve pain management for both of these patients? But before we can do this, as Patrick said this morning, we actually need to make a diagnosis about what's causing this pain so that we have a clear idea of what direction we're headed in. So what is the known or the presumed cause of the pain? In our patient population, sometimes we want to do the diagnostic testing to find out more about cause, and sometimes we say it's not appropriate to the goals of care to do that. We just need to treat the pain, and we do good guessing, educated guessing about what to do. But if it's cancer pain, we need to think about, is this related to their disease? Does this mean that their disease is worse? Has there been progression? Is it related to treatment? Is this a complication or a sequela of their treatment? Is it post-mastectomy pain? Is it related to previous radiation therapies? Are they having bone pain because they just got an infusion of zoledronic acid for bony metastases, and that sometimes causes increased pain for a few days? So what is the cause of this person's pain? Is it totally unrelated to their cancer? Did something else happen? What kind of pain is it? This is going to direct you to the use not of your analgesic medications, and also to some of the non-pharmacological agents that you might think about, or therapies. So is it nociceptive pain? Is it somatic? Is it inflammatory? Is it visceral? Is it neuropathic pain? May respond, if it's neuropathic, you may need a whole separate set of pharmacological agents. Is it mixed? How long have they had it? Is this acute? Is it chronic? Do they have a chronic pain and this is now a new acute pain on top of it? So types of pain, remembering that nociceptive pain can sometimes be protective. It's the kind of pain that you get when you have blood drawn or when you have a bone marrow biopsy. I think for kids, and Maria, you can correct me, but from my observation of kids, this is often very distressing to them. They come in, and I see them in our pediatric clinic, and they're crying just thinking about going in to have their blood work done. Somatic inflammatory pain could be from bone mets, it could be from arthritis, it could be a healing incision, but it's connective tissue. Visceral pain, organs are involved. So the thorax, the abdomen, or the pelvis, directly involving internal organs or even the lining of these cavities. So pleural-based pain can be exquisitely painful. Is it neuropathic pain? Neuropathic pain means to me that the nervous system, thank you, she's a good nurse. Neuropathic pain means to me that the nervous system is damaged. Something is wrong. There's abnormal signaling that is being, the brain is interpreting as pain. What's happened here? Is this the effect of a post-herpetic neuralgia? Is it neuropathy from chemotherapy or nerve root compression from bone mets? Is it some kind of a post-pain or post-radiation syndrome? So for Henry, as you think about his history and his presentation, what you need to think about is, if this is cancer-related pain, what is most likely causing his pain? Could this be somatic pain because of right hip and L1-2 vertebral involvement from his disease? Is this mixed somatic and neuropathic pain related to bone lesions and possible L1-2 lesions causing nerve root compression or other nerve compression? Or is it pure neuropathic pain of the right hip related to referred pain from an L1-2 vertebral involvement? Or is this degenerative changes?
And for Sally, again, the same thing. Is this somatic pain from her left arm related to known and possible disease involvement? Perhaps is it neuropathic pain related to the bony lesions that are appearing, or even neuropathic pain to the left arm related to referred pain from lung involvement? So we need to look at, whether there are degenerative changes, which one, does it matter which one it is? I don't really think so. Other than we need to get to making sure that we address each and every one of those possibilities in the best method that we can.
So for Henry, what would you do in terms of diagnostic testing? Does he need more? Should we do more? Do we have enough information to do a good overall pain management plan that moves beyond just giving him more medication? How many people think we have enough information? Okay. How many people think we need a little bit more before we can really have a good plan? Okay. So what are we going to do for Henry? What would you think? What's your most likely diagnosis for him? So the first thing you think about, is this an oncologic emergency? Does he have a sort of developing cord compression that's causing this pain? So you weigh the risks and the benefits of getting more information. If he has a cord compression, that's a very different path that we're going to walk than just here, take more morphine. So we need a little bit more information. So for him, I think the thing we want to do is to do the MRI and find out if he has a cord compression or if he's had progression of these L1-2 known disease places. And then the next question then becomes, based on the information we have, in our preliminary, our presumed diagnosis for him, what will be our pain management plan?
And in terms of Sally, the same type of things to consider. Would an MRI of the left arm or chest or a CT be of any benefit in terms of, is it going to give us more information, or is it going to be too much for Sally to go through that? And again, the other consideration with pediatrics is back to their experiential. I don't know if any of you have been with children who've had to go for ongoing treatment in terms of MRIs or CTs. For some children, it's just, I don't even know how some adults do it. They find it quite claustrophobic. It's almost like they're going through a post-traumatic stress reaction. And so just the thought of having to go have those procedures done, even if it's just for imaging, sends them into anxiety. So it's going to be very much about weighing those risks and benefits. Is it going to hurt us if we just start her on some neuropathic medications for pain, even if the CT was going to show that there isn't anything there? So part of that is knowing the child and knowing, what we're going to need to do based on that individual assessment that you've done. So how are we going to treat things? So again, another mnemonic in the hopes of helping you remember, because I don't know about you, but I know that for me, my brain has become very small as I've aged. It's matching my body. I think it's shrinking now, and there's only so much information I can keep in there. So mnemonics help me. So again, treat treatable causes. Are there things that we can treat? Let's think about that. Making sure we optimize whatever it is that we're doing. Let's make sure we optimize it. I know so many times I've gone into, in particular, in areas where, their experience with pain management is very much post-operative. The idea of palliative and end-of-life pain management just scares them. And oftentimes they're like, well, maybe if we just give them a little whiff of morphine, that'll just do the trick. And it's like, a whiff of morphine's like, how would you like a whiff? Just to get, satiate your appetite and then, And again, I think part of it is that fear with regards to children. But optimizing your analgesic medications is very important. Nonpharmacologic modalities, and again, this is where nursing, you are the stars, you are the forefront, you are the people who, because in general, I think you are the ones who will be the first to think about this. And I'm not saying that you necessarily have to be doing this, but if you look at the WHO ladder in terms of how you escalated opioids even, you have to look at that idea that what's all along that ladder, adjuvants and non-pharmacological approaches, those things have to go hand in hand. It's just like, the idea of, if you order an opioid, you order a laxative, you need to do them together. And then considering invasive procedures, sometimes those make sense. And so, the idea of spinal analgesia, the idea of things, radiation, things that perhaps seem quite invasive may make sense, but it will be based on a really good assessment and ensuring that we understand what the diagnosis is and what's the best approach considering all the individual variables of that patient and family. So treat the cause. Consider if the cancer is related to surgical interventions or surgery. And I think Maureen can speak better to this in terms of adults, but I know for myself, in terms of our population, I always go to children with who've had amputations and looking at, have they had, an amputation? Have they had a surgical intervention? Are they having phantom limb pain? Is that what it's related to? And for some children, do they need to have their having their ascites tapped, if they need to go in and they're having liver disease, and it may help if they have a drain put in. Chemotherapy, oral chemotherapy agents, IV, those are all important parts of treatment and in terms of treating pain and management of pain. Radiation therapy is a mainstay, I know, in pediatrics for ongoing pain management, in particular with children who have bony mets as well as brain tumors. And then in biologics, I wasn't sure what you were thinking, Maureen.
I think the biologics have more to do, it used to be interferon and interleukin-2, but now we have a lot of targeted therapies that have come along. Things like Rituxan and Herceptin and other things that we kind of lump into, now they're kind of smushed into chemotherapy, but just depends on how you differentiate them.
Okay. Perfect. So non-pharmacologic interventions, and part of the reason I'm speaking on this is just we tend to automatically do this with children because they seem more receptive. And back to what Jody was talking about this morning, just that idea that there are other things that we can do. So heat and cold, massage, and in fact with massage in pediatrics, and there are some studies even in adults in oncology, massage is starting to become standardized treatment for some types of pain in oncology. I can't cite you the articles right now because there's not that many, but our center is now just embarking on a study of massage therapy because part of our complementary therapies program is massage. And we're finding our children, in particular with osteosarcoma or neuroblastoma, seem to be responding very well in terms of feeling, just a generalized feeling of wellness, less fatigue, with massage therapy. So it's doing well. Physical therapy, PT, that idea of getting up and moving around. TENS, does everybody know what TENS are? I have less experience in pediatrics with the TENS, but certainly there is some evidence to demonstrate that it can work in conjunction with. So the idea is that none of these things are meant to work in isolation or alone. Distraction, relaxation, music therapy, meditation. I know that there's a big movement right now in the Canadian hospice palliative care world around mindful meditation. I don't know if that's something that has taken hold of in the United States, but I have certainly seen some absolute, it's the idea of actual focused meditation with someone kind of talking you through. So it's really another way of just going through distraction, but it's really a whole way of being, and it can work with children as young as 4 or 5 years old. Acupuncture and energy work, very important, and certainly there are limited, but there are some studies in pediatrics that show acupuncture does work. It really does work as a additive modality in pain management. Other things to make sure you think of is that what they're doing, they're not in place of, but they're enhancing. They're actually working as adjuvants, and oftentimes what we find is, in conjunction with the medication, they make things work better. Sometimes they can reduce the need for medications and actually reduce risks of adverse effects from drug interactions. Certainly, they help empower the child and family, make them feel like there's something I can do. I have control. I can decide what kind of music. I may not be able to decide, the medication that's going to work, but I can decide what kind of music I'm going to listen to while I have to go through this. So you cannot underestimate the power, both for children and parents and adults who are their caregivers, that idea of empowerment, the choice that I get to choose what this is. and just also helps meet those psychosocial needs. So that idea of the total pain experience, this is addressing that. Complementary therapies are great for procedural pain. There is Cochrane collaboration. I don't know if anybody accesses the Cochrane collaboration. It's just a kind of like a clearinghouse of evidence-based information. And they've come to demonstrate, in particular with infants and neonates, the use of sucrose for pain management and sucrose for procedural pain. Evidence shows that it works. It reduces the pain response. Certainly complementary therapies have been used with disease-related chronic and recurrent pain and acute and post-operative pain. So it's important to know that they can go through the entire trajectory. Some examples here are things, that you don't think of, but they're evidence-based. They do work. They've been demonstrated, and these ones I highlight only because they're things that you wouldn't think about. For infants, familiar voices. You've seen a young baby respond when they hear their mom's voice, when they see their father's face. They know. Sucking, swaddling, dim lights, just great, we call it developmental care. Cognitive and behavioral methods, you heard a little bit about that today. Distraction, imagery, hypnosis, self-hypnosis. There are some programs, pediatric programs. I'm sure there are adult programs. I was fortunate enough to have a chance to see the program at Minnesota. In terms of self-hypnosis, children as young as 6 and 7 can learn it if you have the right person who's trained to teach it. Relaxation techniques, again, we've talked about that, physiological methods, and then other methods.
So Maria mentioned the interventional techniques, and I think, I put those always at when nothing else seems to be working or we're running into side effects with our more traditional ways of managing pain, that we need to then look to our anesthesia and our neurosurgical colleagues and say, what can you do to help? What are the possibilities here? Sometimes sooner, sometimes later. When I think about our oncologic population, I think about the adult patient with pancreatic cancer and some of the studies that have shown that doing a celiac plexus block early in the diagnosis may actually help prevent future pain. So what are we doing to think about how we integrate some of that into our overall pain management plan for a patient? Thinking about spinal analgesics, intrathecal pumps, implanted pumps, neurosurgical procedures, other things that might help. But despite all of that, generally we come back to this idea that medications are going to be the mainstay of what we do in pain management. And our job really is to have a really good idea of how these meds work, how they work together, how we dose them, and how we manage side effects so that we can optimize what's happening for the patient. So as we go through, the basic question here is, so what analgesic changes would you make for Henry? What would you make for Sally? You always go back to the WHO analgesic ladder, and I know that for some experts, they're saying, well, you know what, maybe that doesn't work so much anymore, but I think it still works, and it helps give us a framework of what we're thinking about. So if the patient has pain, the first question to say is, have they tried a non-opioid, plus or minus a co-analgesic? And if that hasn't worked, have they tried an opioid for mild to moderate pain, which these days really probably means more, have they tried short-acting opioids in some dosing form or other? Have they continued the non-opioid? Are they doing the co-analgesic for nerve pain or neuropathic pain if that seems indicated? If the pain persists, then what do we do? An opioid for moderate to severe pain, which generally means that we're adding some kind of a background or long-acting opioid, continuing these other medications. And if that doesn't work, we may then go and say, what's out there interventionally that can be done? And finally, we're hoping to get pain relief. So acetaminophen, let me ask you this. Don't read the slide. In your experience and in your practice, what is the maximum dose of acetaminophen that you recommend? How many are recommending 4,000 milligrams a day across the board? 3. So how many are recommending 3? Anybody down to 26 or 2,400? 2,000? Interesting. The literature is all over the place. If you read the old literature, it will say that 4,000 milligrams a day is the thing. that's great if you take it once in a while for a headache. You know, I think about me. You know, I rarely get headaches. I don't take pain medicine because I'm in pain management. And one night I woke up and I had a terrible headache, and I thought, oh, you know what? I can go take something for this. So I went to look for my Tylenol, which was 6 years old. So I think that for me, I could probably take 4,000 milligrams of Tylenol in a single day for the frequency with which I do it, which is like once every 6 months. I could probably do okay and my liver would be fine. But if you have a patient that's taking Tylenol every single day, you know, what is our maximum dose here? So it was 3,000, and then some of the geriatric literature said, you know what, maybe it's closer to 2,000 or even 2,400 milligrams a day. So it really kind of depends on what the frequency of dosing is, what the age of your patient is. And the other thing you need to look at is what are their liver functions and what are their risk factors. So acetaminophen is not a drug to take lightly. And also, what other medications are they utilizing? If they're taking allergy medications that have acetaminophen in it, you know, that reduces what's available in terms of pain management. Nsaids, commonly available over the counter. How many people confuse, well, you know, I knew I shouldn't take any more ibuprofen, so I took some Motrin. I knew I shouldn't take more Motrin, so I took some Aleve. Great. So there's a lot of confusion about who are these drugs that are over the counter and what do they do. People don't understand their mechanism of action, but they are effective for many types of somatic pain. So if the patient has bone pain, they have arthritis pain, if their stomachs will tolerate it, if their liver and their kidneys will tolerate it, if their platelet count will tolerate it, they're not a bad drug. It's actually a great drug. Each drug in this class has a different ceiling dose, so you need to know which of the drugs you're dealing with most commonly. So for ibuprofen, it's around 3,200 milligrams a day. But for naproxen, which is the Aleve product, it's 1,500 milligrams a day. So you need to understand what those different things are so you're giving people good information. What are the side effects? Very common to get GI side effects from taking these drugs, even in the short term, even if you take them with food. There's some evidence to say that if you take them with a PPI or this drug called Cytotec or misoprostol, which is a more expensive way to do it, that you can limit the incidence of GI incidents. You can have a GI bleed and never have had dyspepsia. That's a scary thought. What about the renal and hepatic damage that can occur with chronic use of these drugs? I have had patients that have come in, perfectly normal LFTs, suddenly they're off the charts, and you think, what happened here? So you say, well, what's been going on? What have you been taking? And they say, well, I've been taking the meds the way you've been prescribing them. Well, what else have you been taking? Oh, well, maybe they weren't so great, so I decided to add some ibuprofen in. And then you find out that they've really been sort of maxing out on what they've been taking for ibuprofen, and that's caused their LFTs to go up over the course of a week or even 2 weeks. So really watching for that, watching renal function, watching these drugs in patients that may have sort of chronic renal insufficiency, and really weighing the risk-benefit for that patient and their goals of care, and is it worth adding it at this point. Patients that have bleeding problems. I worried about Patrick's patient George this morning. So George had a crit of 5.7 and he had leukemia. What are the odds that he had a low white count as well as a low platelet count? Would you give George ibuprofen if he told you he was having pain? No, definitely not. You increase his risk of bleeding, and he may also be somebody that has some chronic renal insufficiency from his past chemotherapy. So really looking at the whole picture of the patient. So then we say, well, that's not a problem. If they have low platelet counts, we'll just give them Celebrex. That's no walk in the park either. So over the first 6 months of use, there may be less gastric ulceration, and there's minimal inhibition of platelets, but now we have to worry about the cardiovascular effects, probably because of the inhibition of platelets, or the lack of inhibition. So what's happening with all of that? Do we do this? Will the insurance pay for it? I work in outpatient oncology, so one of my first questions always is, what insurance does the patient have? People think I'm mercenary because I'm looking to get paid for myself. It doesn't matter to me. Dana-Farber's going to pay me whether the patient has insurance or not. But the question is, for this patient, what's it going to cost them to get whatever I'm going to prescribe? Thinking about co-analgesics. So if this person has neuropathic pain, or if we suspect neuropathic pain, those are when we start looking at the co-analgesic medications. So these are drugs that are used primarily for something else, but we find that they enhance analgesic effects in some circumstances, which is the nerve pain. So the drugs that we most commonly use as co-analgesics are anticonvulsants and antidepressants, so certain types of antidepressants. There's also corticosteroids. So if we strongly thought that Henry had a cord compression, one of the first things we might think about for him is, should we add a steroid, a corticosteroid? What's the risk-benefit of doing that for him? If we think about the anticonvulsants, the most commonly prescribed one is probably gabapentin or Neurontin. I think about pregabalin as sort of son of Neurontin. It's kind of the same mechanism of action, but some of the pharmacokinetics of the drug are slightly different, so it may work a little bit better, a little bit faster, have a few less side effects. There's also some evidence for the use of drugs like Tegretol, Lamictal, Topamax, Keppra, and Trileptal. Not as much. What's your comfort level in using those drugs? Frankly, I have none. If I've tried gabapentin and it didn't work, and then I tried pregabalin, and I tried adding a tricyclic, and somebody has bad neuropathic pain, I'm on the phone to the anesthesia guy saying, okay, help me think this through, or to the neurology guy saying, help me think it through. Knowing what the side effects are, thinking about, is there a role for lidoderm patches? How deep is this person's pain? Will the patch really help? What's the expense of the patch? So Neurontin. One of the common things I hear is, I was on Neurontin and it didn't work. So my next question is, how much were you taking? 100 at night. So what happened? They stopped it because it wasn't working. Well, the typical effective dose of Neurontin is 900 to 3,600 milligrams a day. There's actually a saturable transport mechanism in the gut that limits how much an individual person can absorb of Neurontin. So it may well be that you hit a point where somebody's not going to get any more analgesic effect out of it, but it's typically not at 100 milligrams a day. So somebody hits around 1,800, 2,700 milligrams and it's not doing much, I might say, maybe we need to think about something different here. The nice thing about Neurontin is that it's generally well tolerated and it doesn't have a lot of drug-drug interactions. So Lyrica, same mechanism of action as gabapentin. Dosing is a little different, so you can start with as low as 50 milligrams a day. Typically effective dose is around 300 milligrams a day. I actually have a couple of patients that are on up to 600 milligrams a day, and that seems to work. And in the seizure literature, that kind of dosing is not out there, so I felt pretty comfortable doing that. It is more efficiently absorbed, and so you get a more straight-line pharmacokinetic out of Lyrica. And for many people, not the sleepiness and the tiredness that you see with Neurontin. So it's good. It is the second-generation drug, so what happens in terms of insurance? Insurance often says you need to have failed Neurontin before we will provide Lyrica for you. I just got a rejection from an insurance company Thursday when I left work saying, you can't have Lyrica until they've also failed a tricyclic antidepressant. Thank you so much. So tricyclic antidepressants, very old drugs, very inexpensive drugs. They're rarely used for depression anymore, but there's a lot of good literature to support their use for neuropathic pain. They work faster for pain than they do on depression, and the doses are typically around 50 is high. I usually start at 10 milligrams a day, and usually between 10 and 30 is where you can see a relative effective range for pain, although sometimes it goes higher. They do have anticholinergic side effects, so you have to be very careful in using them with elderly patients and patients that have cardiac conduction abnormalities or bladder outlet obstruction. They're going to cause dry mouth, and they're going to cause constipation. So thinking about what's the mix of medications you're using for your patient. SSNRIs, such as venlafaxine or duloxetine, which is Cymbalta, and a lot of people come in and say, oh, Cymbalta, I saw that on TV. Is that good or is that bad? So, these are the drugs that have been FDA approval for duloxetine is for some types of peripheral neuropathy. It's for fibromyalgia, as is Lyrica. And I always get this mixed up, and I always say I won't forget, but one of them also has approval for chronic musculoskeletal pain, and I think it's Cymbalta, but I'm not sure. So knowing what those doses are, when are you going to use them, what other drugs are they going to interact with? If you have a patient that's already on citralopram or Celexa, is that a person that you're going to think about giving Cymbalta? No, because you're going to get cross-reactivity and the increased risk of serotonin syndrome. So knowing how to use the co-analgesic medications, having a comfort level with at least one or two alternatives so that you can think about how you're going to use them, and then thinking about, okay, how do I maximize my use of opioids? How many of you would say that you're pretty expert at the use of opioids? Yeah, so probably a lot of you are. So we're going to go through this pretty quickly. So opioids are usually for moderate to severe pain. They're partially effective for neuropathic pain. And the ones that we use most commonly are morphine, oxycodone, hydromorphone, fentanyl, methadone, oxymorphone, and hydrocodone. Barriers to use. How many people know about REMS? So risk evaluation and mitigation strategies. How many of you have had to do a REMS in order to write an opioid script recently? The REMS right now seem to be attached to the short-acting fentanyl products, so on Solus, which is the film that you can use, and we'll talk a little bit more about that. And there's a new fentanyl formulation that dissolves under the tongue. It's called Abstral. They have REMS attached to them. So REMS means that as a provider, I need to go through an educational program and I need to pass a test. It also means that the pharmacy that's going to dispense this needs to say that they understand how it's used and will educate the patient in proper use of this medication. It also means that the patient needs to be registered to use the medication. So the REMS may be different for different products, but I think we're going to see more and more of this as we think about prescribing opioids. There's legislation that's been on and off the books around using the REMS for almost all long-acting narcotics. So OxyContin, MS-Contin, any of those drugs may have this. What do you think that's going to do to our premise of primary palliative care and doing good basic symptom management at the level of the primary provider? It's going to kill it. I think it's going to be a very difficult road. I can see many of the oncologists I work with saying, I don't have time to do this. If they need those meds, they're going to have to come to you. I have to tell you that we're in an organization where there must be 300 oncologists. There's one of me. So how's that going to work? Patient issues, fear of addiction, fear of diversion, fear that they'll be robbed because they have these medications. Cost of the medications, cost to the patient, insurance co-pays, and even though they have insurance, sometimes the co-pays can be $50 per prescription. And what's their availability? Maria and I were talking about that. In Canada, it sounds like they have an even more difficult time because they have national legislation, then they have provincial legislation, and they even have interprovincial differences in how we do it. At least we deal with the FDA, and most of the states will go along with the FDA. Now, we do have regional variations in availability of drugs, but that has more to do with the commonality of how the drugs are used. So for Henry, we think that he's got constant pain despite chronic use of an opioid in pretty good doses, pretty consistently. So he probably does at this point require a background analgesic. And for Sally,
the same thing. May require an increase in the background and additional co-analgesics, and perhaps also an addition of some medications for neuropathic pain.
So how do we think about this from here? So if we think about background opioids, we have a whole slew that we can pick from. We have long-acting morphine products. We have a new long-acting hydromorphone product that's out there, Exalgo. We have OxyContin. We have Elpana, which is Oxymorphone. We have the transdermal fentanyl patches, and we have Methadone. And these drugs come in various, tablet form, liquid form, patch form. So how do you pick one that's best for your patient? How do you pick an opioid for breakthrough or incident pain? How do you dose it? One of the biggest mistakes we see in pain management is how people do breakthrough pain dosing. So we'll see somebody like Henry that comes in on his 2 Percocet, and you may end up titrating him onto a long-acting opioid. Let's say he gets morphine, and you titrate him up to 100 milligrams twice a day. long-acting morphine, and he's still getting the 2 Percocet for breakthrough pain. So people don't understand the relationship. So a breakthrough dose needs to be about 10 to 20% of the total 24-hour dose of oral morphine equivalent of the background drug. So if he's on 100 twice a day of long-acting morphine, that's 200 milligrams. So his breakthrough dose would need to be at least 10 to 20 milligrams of oral morphine equivalent. The example that's on the slide is a fentanyl patch. 150 microgram patch is equal to about 300 milligrams of oral morphine in 24 hours, so the dose of oral morphine would be 30 to 45 milligrams for a PRN dose. So what will Henry's breakthrough dosing look like? And what should we pick for him? Is Percocet going to still be the drug of choice for him? So we can pick morphine, oxycodone, oxymorphone, hydromorphone. It comes in tablets, it comes in liquids. We can do rectal suppositories. If he says to you, you know what, I really like the Percocet, I want to stick with it. So then you got to say, well, okay, well, Percocet or combined oxycodone and acetaminophen comes in multiple ways. You can actually get a 10 milligram oxycodone, 325 milligram acetaminophen tablet, which may allow him to continue to use that for a little bit longer. So what are you going to do with that? We have the rapid-acting opioids, which are all fentanyl-based. So we have Actique. How many people know about Actique? So the lollipop. What's the drawback to the lollipop? Cost is one. It's also the effort it takes to use it. You got to keep it moving. You can't just put it in and park it, because if you do, you lose almost 50% of the dose. So it's got to be kept moving. Fentora overcame that by saying, well, all you have to do with this is pop it in your mouth and put it between your upper gum and your cheek. But what happens if you have a dry mouth? It doesn't work. On Solus is a film. It's kind of like, the Listerine film things. You put it on your mouth and it will dissolve over time. Abstral is one of the newest ones on the market. That's the tablet that dissolves under your tongue. The drug rep came by, of course, and said, here, try the mock product. So I said, okay, fine. I actually was pretty impressed at how well it absorbed or how quickly it dissolve. So that may have an edge maybe for some patients, but cost and availability are going to be an issue. And then the newest one that's going to come on the market is Elizondo, which is going to be the intranasal fentanyl that's going to be commercially available, that will be coming out probably in the next couple of months. So how do you pick an opioid for Henry? How do you pick an opioid for Sally? What do? Do we stay with her hydromorphone, long-acting and short-acting? Do we change it? What do we do with Henry? He's only on Percocet. So how do you pick an opioid? Patient preference and experience. One of my favorite questions to patients is, what have you tried in the past? What's worked, what hasn't? Drug pharmacokinetics. Simplistically stated, all of the opioids are metabolized in the liver and excreted in the kidneys. If you have poor renal function, what happens to your ability to excrete an opioid? And what happens if that opioid has an active metabolite? What if you don't have the liver function to break the opioid down? Maybe IV is a better route. Maybe sub-Q is a better route. What's the availability of the dosing forms? What's the cost? What's the insurance coverage? What's the route of administration that you want? How many of you use sublingual routes? Okay, what's the evidence? There's not good absorption of anything that's hydrophilic through the sublingual route. It's actually probably being trickled down into the throat. So nebulized opioids, and I know Patrick spoke this morning about fentanyl, and we won't go there. But morphine, there really isn't a lot of evidence that has any benefit, and it doesn't make sense because it's a hydrophilic agent. So then they did studies to say, okay, well, what happens to sublingual morphine? 18% of the dose is absorbed by the sublingual mucosa. So it's not a whole lot. Fentanyl actually is better absorbed, which is why the sublingual fentanyl products are on the market. Buprenorphine or Suboxone, available for addictions, is given sublingually, and that does have a pretty good absorption rate. Methadone, maybe a little bit, oxycodone, not so much. So that's kind of the data. If you think about transdermal, subcutaneous injections, IM injections, and Maria added this notes about it's never recommended in children. It's almost never indicated in an adult. Why would you do it? There's evidence of erratic absorption, and it hurts like heck. So IM is probably not a good route. Intravenous is intranasal now with our new fentanyl products, and spinal. Anybody using meperidine, Demerol? Thank God. Propoxyphene is off the market. The FDA pulled it. We have Ultram, and sort of the next generation, and I know that the pharmaceutical company wouldn't appreciate it, but Nucynta or tapentadol works by kind of the same mechanisms as Ultram. So weaker opioid receptors, reuptake of serotonin and norepinephrine, so kind of that mechanism of action. Ceiling doses for each of them. They do have side effects, but for the patient that says, I'm not quite ready to go to the stronger opioids, these drugs may be a way of bridging. Morphine is the standard active metabolite, hydromorphone. Oxycodone has no active metabolites, but it does require and I forget if it's a transport mechanism, but there's some enzyme that many people are lacking to break down oxycodone into the active drug. So when people say to you, it doesn't work for me, they may not be kidding about that. Fentanyl, we talked about. Codeine, not so much used as an analgesic anymore because after you get to a certain dose, you don't really get a good analgesic. There's a ceiling to what you're getting out of the analgesic. But as you keep giving more and more, you get increasing side effects. And Maria's noticed that it's not used in children. Methadone is lipophilic. It has a long and variable half-life that can lead to drug accumulation and sedation. It also can cause QTc prolongation. So before you do methadone or as you're increasing methadone, and again, risk-benefit for the patient, do you need to get an EKG? Do you need to recheck an EKG? It may work as an MNMDA receptor antagonist, which may make it useful for neuropathic pain. And the equally analgesic doses are all over the map. If you work in an organization and you are using methadone, my recommendation is that you sit down with the pharmacy, the physicians that you work with, and your entire team, and you look at the literature and you decide how you want to do methadone equally analgesic conversions so that at least everybody's doing it exactly the same way, and it's based on what the evidence is showing. And the evidence is a little bit all over the map. There's multiple drug-drug interactions with methadone. Some of them are just listed on that slide for you. We talked about this, and I'm not going to go through them too much more except to say that the three forms of the fentanyl rapid-acting are out there. Oxymorphone is a relatively new player. Are people using oxymorphone? Yeah. Haven't quite figured out what its niche is. One of the drawbacks for me is that if you do Opana, it says that you can't eat for 2 hours before or 2 hours after a dose because taking it with food increases the drug absorption. So I haven't quite figured it out, but I think that for some patients, it might be a reasonable option. Transdermal fentanyl, chronic stable pain. In our patient population, I worry about what's the hydration status, how much fatty tissue do they have to really make the fentanyl patch absorb. With the multiplicity of generic fentanyl patches on the market, what is the staying power of the patch when it's put on? Are people having trouble with it sticking? Where are they putting it to get it to absorb? Are they really getting everything that they're paying for out of the fentanyl patch? So if we think about Henry and Sally, we may be thinking that we want to change up drugs on them, particularly for Henry. He's been exposed now to oxycodone, but are we going to give him OxyContin as a breakthrough pain medication? Is his insurance going to allow that? Is the insurance going to say you need to start with morphine? What are we going to do with that? What are we going to do with Sally? Should she stay with the hydromorphone? Should we switch her? If we're going to think about switching drugs, we need to have a reason for it. So with Henry, we may well decide to do something different because of insurance and cost. But also if there's side effect issues, if they become too sedated, if they have persistent nausea and vomiting, if they have itching to one opioid or urinary retention, they may not have the same side effects to other opioids. So that may be one reason to think about switching. Compliance. Are they having trouble taking the doses on time? Can they manage the tablets? Would they be better off with a transdermal patch if they have adequate hydration and nutrition to absorb it? I always get upset when I get emails from the oncologist saying, you need to come and see this patient. They're on OxyContin 10 milligrams every 12 hours and it's not working, so I think they need to go to methadone. Help me understand that one. Because that may just be a dose response to the drug. It's not the drug itself. Now, maybe they're one of those people that can't break the OxyContin down, but I think at 20 milligrams a day, we haven't quite proven that case. So if we're going to go from one drug to another, we need to understand about equianalgesic dosing. Is everybody okay with that? Okay. So you know everything on here is, every dose is theoretically equivalent to the other, and you can cross-multiply and go up and down. Okay, now we're talking about peds. I'm out of here.
I put this up here just as an opportunity because I know the big thing with in terms of pediatric and opioids, people just get really, really nervous. And so my big thing to remember is all the same principles. What Maureen was talking about all applies, the equianalgesic, all those things applied. You just need to remember it's weight-based. So if this is an opioid-naive patient, start at your low end. That's it. That's all. Just start at what's recommended. You go open up, we call it a CPS, which is just our drug book. You go look it up, and you'll see in there, not recommended for children, not recommended for children, not recommended for children. Nothing's recommended for children. Okay then. So we're just, but if you are working in in a center or an area where you don't have a lot of pediatrics, but you're going to get the one-off case, call your local hospital and get their pediatric formulary, and they will talk to you about the doses. But this is the average, starting places, and this is where we start. For in particular, as I said, if it's an opioid naive patient, that's where you start. If it's not, then don't be afraid. And we're going to talk about, how do you go up incrementally, and you should do the same. I told you about that young boy with neuroblastoma who was on the 200. Did I say 200? 200. That was just of the one opioid. He was also on a hefty dose of ketamine, gabapentin, doses that, and actually midazolam infusion that got as high as 8 milligrams. And he couldn't have weighed more than about 40 kilos. So again, you have to treat the pain. And we went up incrementally, and we saw, dose response, see how he responded, and we just continued to look at different things. But it's, as I said, it seems scary, but really your basic information. Where am I starting? Has this patient had opioids before? If yes, then I don't need to start at the low end. I can, move my way along and reassess and reassess and reassess. And that was my only point in putting that up. It looks like the doses are so small. Like, how do you draw up 0.025 of, it's possible. And if it's something that's very new to you, call up your local pediatric hospital with their own formulary and get that. And there are lots of resources, and I've put them at the bottom there of that chart where you can go, and they're free. You can download their actual formularies so that you can see where they would start.
So we're realizing that we're short on time, so we're actually going to skip through some things. Incomplete cross-tolerance means is if you go from one drug to another, you need to decrease the dose slightly because they're not going to tolerate it. The directions for how to do that are in your slide material. We're going to skip through the titration piece in the interest of a couple of other things that I think at least are important. Yes. One of the things that I think that we need to think about is the whole issue of addiction. So as you talk to Henry and you decide that you're going to add a background analgesic and you might need to increase his doses, and his mother says, let's face it, he's just getting addicted here. Let's not do this. And then, Sally's parents have a similar concern. Where did they go? You took them out?
No.
They disappeared.
Oh.
Sally's parents have a similar concern. So how do you respond to this? So, one of the things is that you want to explore their concern. When you think about addiction, what are you talking about? What is it? I hear it all the time. Well, I don't really have a specific concern. I just heard about it on TV. So what does that mean? Do they have a history that makes you think that we should be concerned? And hopefully we've already asked that question as part of our assessment data. Is there a history of this in the family that they're now worried that bringing the drugs in is going to just bring it up? And if so, explain how we have a responsibility to help them to manage their medication so that this doesn't, not that it doesn't happen, but that we're keeping track of it and we're keeping an eye on things too. Oh, there they are.
I don't know how that happened.
Okay. So the other piece that I just want to talk about very quickly in the interest of time, I'm doing it again.
Yeah, you're going backwards.
How's that
Yeah,
happening?
you just go, maybe you've just, yeah, that's right, keep going.
You getting all this? Okay.
There, yeah.
All right. This is the one. When we think about providing pain relief, your pain management plan is not done until you have educated the patient and the family, as much as the patient will allow, or if it's pediatrics, it's probably primarily the family, about how do you manage side effects. Remember that it's not just about pain relief, it's also about improved function, and a part of that is that you can't have unmanageable side effects. So what do you do with that? Somebody said that the hand that writes the opioid prescription does the disimpaction. I agree with that. You know, I think that constipation is such a common problem that as soon as you start talking about opioids, you are also talking about, and here's what you're going to do to prevent constipation. It can't be just a stool softener. You need to add a stimulant laxative. People will worry about respiratory depression, but it doesn't happen in the tolerant patient. Neurotoxicities, cognitive slowing, sedation, myoclonus, delirium, hyperalgesia. Why is that happening? Is it happening as you increase the dose of the drug? Do they really need this amount of opioid? What's their metabolic state? Can they manage this medication? Can they manage the breakdown of the medication? Are they having nausea, dry mouth, itching, sweating, or urinary retention? I know you want to say something about...
So, and just in terms of, I think that's one of the little differences is that when pediatrics, in fact, itching and pruritus is, there's not a lot of literature, but the literature that's out there, 30% of patients, pediatric patients on opioids will experience itching. And that seems to be the most bothersome next to the rest of them for children.
Then I guess I'm anally fixated. I want to say one more thing. Constipation. How many of you have used methyl naltrexone? Okay, great. So you guys are well aware of this injectable opioid antagonist that you can use in palliative care, because that's part of the indication, to reverse opioid-induced constipation. So if somebody's asking you about this, the first question is this opioid-induced constipation? And there, I think we have 5 minutes for questions. How's that? Okay. All right, so questions or concerns in 5 minutes or less.
Can you go to the mic, please? Just because it's really hard. I've been at both sides now, and it's really hard to hear people, and I want to make sure, because I'm sure if you have a question, somebody else is also thinking the same thing.
I have two questions. One is, can you address the every 8-hour background opioids versus the Q12? And also, does codeine have any additional benefit when there's chest pain or coughing?
Okay, so does codeine have any additional benefit? Probably not. I think that we got used to it because there was codeine-containing cough syrups. Why? Because you can call it in, right? You can call it into the pharmacy. But if somebody's on opioids and you're trying to manage cough or dyspnea, you don't need to add a new opioid. You can just maybe increase slightly the doses that they're already using. There's no, and I hear this all the time. They're on 240 milligrams of OxyContin a day and taking 100 milligrams three or four times a day for breakthrough pain, but we're going to add a little bit of morphine for their cough, okay? We don't really need to do that. We can just have them take a little bit more of the oxycodone if they need to. OxyContin, MS-Contin, some of the long-acting preparations were initially designed to be every 12-hour dosing. What we have found in clinical practice is that it doesn't always last that long. And so your choices are that you either increase the dose that they take every 12 hours or you change to an every 8-hour schedule. So some pharmacies and insurances would balk at this, but it does seem to work out clinically. Here's what I think about. If you're going to go to an every 8-hour schedule, that really commits the patient and family to every 8 hours. So can they do this? Can they do 6 in the morning, 2 in the afternoon, 10 at night? Are they going to be up at 10 at night? Are they going to be up at 6 in the morning? Are they better off with an every 12-hour dosing schedule because it's simpler for their lifestyle? Will the insurance pay for this? Will they allow us to give them that amount of medication? And then what's the dosing form that you're looking at? So if you're looking at giving somebody 180 milligrams a day of OxyContin, is it simpler to give them 60 milligrams every 8 hours, or to write 2 prescriptions for 60s and 30s, because most insurances won't let you do 3 30-milligram tablets, or even more than that, to get to your 180. So how are you going to do that dosing form and get one? Can you do it in 1 prescription versus 2, because that's 1 copay versus 2? Very practical way of thinking about it.
And I think the issues are the same. We would look at those same concerns. You know, it doesn't seem to make more sense to do it every 8 versus every 12, especially one in terms of the child's schedule, as well as just, you know, the idea of what's happening with that child and family and their ability to tolerate. And for some children, it just increasing the frequency helps enormously. And for others, it's just one more thing to have to take, and that's too much. And that was the other emphasis that I wanted to make, is that what we get stuck with sometimes in peds is this idea of how are we going to deliver this. And it's important to remember that while they say by the mouth is where you should always go, remember with some kids, in particular with kids who've had terrible experiences with their treatment regimes, they have mouth aversion. They don't want anything. They have a hard time swallowing pills. So that's a tough thing. Sometimes they prefer liquid to pills, or sometimes they prefer pills to liquids. So really try to be creative in terms of, and I know in Canada we use our compounding pharmacies a lot to say, okay, what can we put all together in a little gummy bear that they'll take? And so we love our pharmacists because they're very creative. We push them to creativity to make this work for a child who, you know, for whatever reason can't take something by mouth, doesn't have access to their port anymore, all sorts of things.
And the one thing I would say, in the States, particularly with adult patients, if you're not working in hospice, compounding pharmacies may be more expensive. They may or may not be covered by insurance. So that's one of the things you really need to check out. Okay, thank you.